on page N1. Narcotic pain relievers. Now, I got to tell you a little bit of the ancient history of narcotic pain relievers. I'm not testing you on it. Narcotic pain relievers were originally and still are made from opium. Opium is grown. It's called the opium poppy. A relative of the opium poppy grows in California. That's the California poppy, the state flower. Anybody familiar with the state flower? It's a yellow flower. It grows all over the state. It's called the California poppy. But there's a relative of it that grows in the Middle East, in Turkey. Actually, where it's grown the most is in Afghanistan. That's their major cash crop. If Afghanistan is growing opium. All right, and so it's found indigenous in Iraq and Iran and so on. They have found ancient hieroglyphic records dated 4000 BC in ancient Sumeria. Anybody know where ancient Sumeria was? You may not remember that? Remember your history? Iraq. It's right in where the Tigris and Euphrates rivers cross. That was ancient Sumeria and Mesopotamia, that cradle of civilization. That's where civilization is believed to have originated, right in Iraq. And they found in ancient hieroglyphics the reference to the opium poppy, and they called it by two hieroglyphic symbols, happiness and plant. It was the joy plant, or happy plant. All right, so it has been known since 4000 BC that if you took this, it would make you happy. That's why they called it the happy plant. Now, it wasn't until 1803 that they actually isolated one of the ingredients, one of the chemicals that are in the opium poppy resin, and it was called morphine. That was the very first agent that they extracted from the opium poppy. And it was named morphine after the Greek god of dreams, Morpheus. In 1832, you don't have to know any of this history, a Frenchman by the name of Pierre-Jean Robequet isolated codeine. Codeine is also extracted from the opium poppy. In 1939, two Ottos of Germany, Otto Eislev and Otto Schaumann, synthesized an opioid-like drug called meperidine. Now, what is meperidine? It goes under the brand name Demerol. Now, Demerol is totally synthetic. It is not obtained from the opium poppy. It is totally man-made. But codeine and morphine come from the opium poppy. That's how it's made. In 1975, Avram Goldstein identified a natural chemical in our brain that works like morphine. He called it endorphin, endogenous morphine. And in 1977, Solomon Snyder of Johns Hopkins identified the receptor sites that morphine and endorphins act on in the limbic system of the brain, and they became known as the opiate or endorphin receptor sites. So basically, we know that our own brain, our own neurons produce a chemical that kind of makes us feel good. It's believed that the so-called runner's high is in part triggered by a release of endorphins after you work out. It's probably released during an orgasm. Morphine and these drugs simply mimic the action of our own endorphins. But as we've said before, the effects last for hours rather than a few brief minutes when you take morphine. Now, we categorize narcotic pain relievers into two groups, opium alkaloids and opioid synthetics. The opium alkaloids are obtained from the opium poppy. They are actually obtained directly from the opium poppy resin, or they're semi-synthetic. They modify them a little bit. The opioid synthetics are totally man-made, and they have a different molecular structure. Morphine is our prototype of a narcotic pain reliever. Most of what morphine does is it inhibits, it slows down electrical activity in our brain. It does have a few excitatory effects, but it's mostly inhibitory. mostly inhibitory. Specifically, morphine mimics or activates the endorphin receptor sites in the thalamus and limbic system. These are known as mu1 endorphin receptor sites. I don't think it's important that you know they're called mu1, but that obviously if there's mu1, there must be mu2 and mu3. They're different types of endorphin receptor sites. Morphine and other narcotic pain relievers cause sedation. What's sedation? Drowsiness. Lethargy. Lethargy means you're tired, fatigued. Muscle relaxation. Amnesia. What does that mean? You forget, your memory goes. Right? Somebody who's, you know, if you're on narcotics, that's probably not the best thing to be on if you're taking a board exam. Because you're really tired and you can't remember anything. But it does cause a general sense of well-being. This is called euphoria. Euphoria, you feel good. Narcotic pain relievers are all controlled substances. They make you feel good. In contrast, aspirin and Tylenol are not controlled substances. Aspirin and Tylenol do not make you, if you feel okay, let's assume you feel all right. I don't know if you do, it's Monday morning, maybe you don't feel all right, but let's assume you do. So, if you take Tylenol, does it make you feel really better? No. Do you say, really like to get a buzz, get some Tylenol? Give me high on Tylenol. In other words, you don't feel, if you feel okay, Tylenol doesn't make you feel better. Tylenol makes you feel better if you're in pain. If you're in pain, it reduces pain, and it just brings you more to normal. But narcotic pain relievers will actually make you feel euphoric. They make you feel better. Morphine depresses the cough reflex center in the medulla oblongata, and that's why codeine and other narcotics are commonly used to reduce coughing. That's called an antitussive action. I think once previously we had mentioned the word tuss means to cough. And so antitussive means against coughing. And that's why there's the over-the-counter product called Robitussin, because it has to do with coughing. Now, I did mention that while morphine slows down the electrical activity in most parts of the brain, for some reason, it actually increases the activity of the vomiting reflex center. And therefore, it tends to cause nausea. It is very common for people taking narcotic drugs to start to feel nauseous. This is known as an emetic effect. Emesis means to vomit. Incidentally, a drug that stops nausea and vomiting is called an anti-emetic drug. But it actually causes emesis. Morphine also, very famously, causes pupillary constriction. We had mentioned that the clinical word for pupillary constriction is miosis. Dilating the pupil is mydriasis. Pupillary constriction is miosis. And it's a meiotic effect. This is spelled differently than meiosis involving the production of sex cells, which is M-E-I-O-S-I-S. This is just M-I-O-T-I-C or M-I-O-S-I-S. And when people are on narcotics, their pupils, they call them pinprick pupils, is the expression. The pupils become really small. Interestingly, morphine can cause certain visceral smooth muscle in our internal organs to contract, and it can decrease GI motility. It can cause constriction or spasm of the bile ducts, and it can cause urinary retention. Again, I'm not so much going to test you on all these side effects. I'm mentioning this, and if you ever look up a narcotic, you'll see that it says all this stuff. Another thing that morphine and other narcotic pain relievers do is they, for some reason, trigger mast cells to release histamine. And because they trigger mast cells to release histamine, they have a histaminic action. And that tends to include constriction of airways. So narcotic drugs, by causing the release of histamine, cause airways to constrict. That makes it a problem using it with somebody with asthma. Now, very important clinical concept here. Morphine is, of course, used as a pain reliever for severe pain. The clinical principle is that pain relievers, analgesics, are more effective if given before the pain has built up to a high level. I don't know why dentists don't appreciate that more. In other words, commonly they won't prescribe somebody a narcotic pain reliever. They'll say, if you need it, call me. And then the person will call in the middle of the night and they got excruciating pain from some dental procedure, and then you actually have to use a higher dose once you've developed severe pain to knock it out than if you would have simply begun the narcotic pain reliever before you even started to feel the severe pain. Anyhow, morphine is used for patients with terminal cancer, the severe pain associated with certain cancer. It's used for people with MIs, myocardial infarction, gangrene, severe burns. So it is used for serious pain. Morphine is primarily given by injection because it is not well absorbed when you swallow it orally. So most of the time when we talk about morphine, it's not morphine tablets or pills. It's morphine IV drip or morphine being injected. So now we will see, there are narcotic pain relievers that you can take orally. The major adverse reactions, the main one is depression of the respiratory center. That's the biggest concern with narcotic pain relievers. So the biggest concern that somebody, if they take too much, it will depress the respiratory center, they stop breathing, and you can die. It also, by activating the vomiting reflex center, tends to cause nausea. It causes constipation, very common for people on narcotics to get constipated. Urinary retention, mental clouding. What's mental clouding? It's hard to think when you're under the influence of a narcotic. It's hard to do any complicated thinking. And it does have this histaminic action tending to cause bronchoconstriction, constriction of the airways, and even a drop in blood pressure. On page N3, something that I asked you to know for the second exam, and I'm mentioning it again, anytime you take a CNS depressant, as you increase the dose, you go from sedation to hypnosis, that means drowsiness, to sleep, to respiratory depression, to unconsciousness, to general anesthesia, to coma, and death. So we mentioned that in the case of barbiturate sedatives. It's true with narcotic pain relievers. That's always the sequence that one goes through. The narcotic pain relievers cause physical dependency. And what that means is that when you take this for a period of time, the body gets used to the presence of the narcotic drug, so that when you stop taking it, you undergo physical withdrawal. And the physical withdrawal, we pointed out before, is the reverse actions of what the drug causes. So if a narcotic pain reliever causes the pupils to constrict, the withdrawal reaction is the pupils dilate. If the action of a narcotic pain reliever is it lowers blood pressure, the withdrawal reaction is the blood pressure goes up. If the action of a narcotic pain reliever is constipation, the withdrawal reaction is diarrhea. Everything is reversed. If the action of a narcotic pain reliever is to make you sleepy, then the withdrawal reaction is you're wired. So the withdrawal response is basically the reverse of what the drug causes to happen. Morphine is a Schedule II controlled substance. That's the most stringent category because Schedule I is illegal. Those are illegal. In addition to physical dependency, there's psychological dependency. And I said really a lot of things can cause psychological dependency. I'm psychologically dependent upon Chunky Monkey ice cream, but which is great, banana with chocolate chips and walnuts. Okay, but anyhow, so you can become psychologically dependent to anything. But again, because it causes euphoria, it makes people feel good. They really become dependent upon it. Also, there is drug tolerance. Now, drug tolerance is different than physical dependency, although commonly drugs do cause both. Tolerance means that the more you take, the longer you take this drug, your body breaks it down at a faster and faster rate. So you need higher and higher doses to get the same effect. So that's a different thing than physical dependency. We don't necessarily, well, I don't want to say, some people may even have some physical dependency to caffeine, but certainly we all develop tolerance to caffeine. We need more and more to get that same, jumpstart our brain in the morning, because our body gets used to breaks it down faster and faster. There is cross-tolerance among the narcotic pain relievers, so if you're tolerant to one of them, you're tolerant to all of them. Morphine and other narcotic pain relievers should be used with caution. Actually, here we wrote contraindicated with respiratory diseases. Why? Because it causes airways to constrict, and it causes CNS depression. Anybody who's depressed, it's going to cause further depression. A history of drug dependency, you don't want to give them narcotics unless... Now again, when we say contraindicated, obviously if somebody is in severe pain from terminal cancer, we don't worry that they have a history of drug dependency. We don't worry that they have depression. They need pain relief. So, when we say it's contraindicated, it depends exactly what the situation is. It should be used with caution in anybody with epilepsy. That was a combination of epilepsy and diabetes. Epilepsies. It should be used with caution in anybody with epilepsy, diabetes, and pregnancy. And in fact, all drugs should be used with caution in anybody with epilepsy, diabetes, or pregnancy. On page N4, again, you have to be very careful when patients are on other CNS depressants, on sedatives, or taking alcohol. And just think, if somebody is taking Vicodin, and then they have some wine, all right, because then the one makes you sleepy, two of them, they put you in a coma. All right, so morphine, we said, is primarily given by injection. Now, there are other opiate alkaloids. Opiate alkaloids means they are derived from the opium poppy, as is morphine. That includes codeine. Now, the chemical name for codeine, you don't have to know it, is methylmorphine. So chemically, it's very much like morphine, except in addition, it has a methyl, a CH3 group. It's about 1/6 as potent as morphine. In other words, 60 milligrams of codeine is equivalent to about 10 milligrams of morphine. It's said to produce less drowsiness, less euphoria, and less respiratory depression than morphine. And less physical dependency, but interestingly, it's the most constipating. Causes the most constipation. So as you know, in the dental office, they don't usually give morphine. One of the reasons is because it has to be given by injection. Codeine can be taken orally, and you give codeine in the dental office. Now, most codeine is that is usually prescribed is a codeine preparation, a compound, that combines a non-narcotic analgesic with the narcotic pain reliever. What am I saying? Tylenol with codeine. We've all heard of that. They commonly will combine a narcotic, codeine, with the non-narcotic pain reliever like Tylenol. And this has a real benefit because what you're doing is you're reducing pain by two totally different mechanisms of action. Tylenol, like aspirin, stops the release of prostaglandins from injured cells, decreasing activation of pain fibers in the periphery. Codeine and other narcotic pain relievers activate the endorphin receptor sites in your thalamus and limbic system of your brain. Does everybody follow that? So these work totally differently. And they find that by giving two totally different kinds of pain relievers that work by two totally different mechanisms, it's more effective in alleviating pain than just using one type of pain reliever alone. Furthermore, adding Tylenol has one other advantage. If the person happens to be running a low-grade fever associated with their pain, Tylenol is an antipyretic. It reduces fever. Codeine, narcotic pain relievers, have no effect on fever. So that also alleviates any fever that the person might be having. So I want to remind you that Tylenol with codeine comes under what's called a number 4, a number 3, a number 2, and a number 1. And you'll recall that a number 4 is 60 milligrams or 1 grain. And the way that we suggested you kind of remember that is 1 hour is 60 minutes, and that's called a number 4. But the most common dosage that's usually given, the most common dosage is a number 3, which is 30 milligrams or a half a grain of codeine in each tablet. Now, of course, they'll typically tell you to take 2 tablets. On page N5, there's a whole bunch of other codeine products. One that we have mentioned previously is Robitussin AC. Remember, the C stands for codeine because codeine is commonly given as an antitussive to stop coughs. It's a Schedule 5 controlled substance. That's not used for pain, that's used for cough. All right, what is heroin? First of all, heroin is not legal in the United States, but it is a legal pain reliever, narcotic pain reliever in Canada. It is chemically diacetylmorphine. I'm not asking you to know this, but it's diacetylmorphine, and here's the secret of how to make heroin. Get a hold of morphine, which is a legal drug, and add vinegar. Vinegar is acetic acid. When you add vinegar, acetic acid, to morphine, it turns it into diacetylmorphine, or heroin, which is 3 times more potent, all right, than morphine. You're welcome. All right, so if you're dealing with illegal drugs, you want to make things more potent because you can get more money for it. All right, now, what are semi-synthetic alkaloids? Semi-synthetic alkaloids are made from the opium poppy. They're made from the opium poppy, but they are modified. They're semi-synthetic. They've synthetically altered it a little bit. So, oxycodone. Oxycodone is similar in potency and action to morphine. But the main thing is that it can be taken orally. So this is taken orally. Morphine, we said, is given by injection. So it's similar to morphine, but can be taken orally. It's semi-synthetic. Oxycodone by itself goes under brand names including OxyContin. But they commonly will combine the oxycodone with a Tylenol, with a non-narcotic pain reliever, for the same reasons they combine codeine with Tylenol. Because that way it has the benefit of reducing pain by 2 totally different mechanisms. So there are a whole bunch of different oxycodone preparations with acetaminophen, Endocet. And notice the ending, acet, reminds us of acetaminophen. And so it comes in different dosages or different formulations. where in this case there are tablets containing 7.5 milligrams of oxycodone and 325 milligrams of acetaminophen in each tablet, and it comes in other higher doses. On N6, Percocet, same thing. It's absolutely identical to Endocet that we just described. Roxacet, Tylox, they're all the same. So whether we talk about Endocet or Percocet or Roxacet or Tylox, these are just different brands of a combination of oxycodone and acetaminophen. They used to have Percodan. What was Percodan versus Percocet? Percodan had oxycodone and aspirin, and Percocet is oxycodone and acetaminophen. And they also have Combinox. Combinox is oxycodone and ibuprofen. Same difference. It doesn't, they're combining a narcotic with a non-narcotic. Now, what is hydrocodone? Hydrocodone is half as potent as morphine. So in other words, this is weaker than oxycodone. These are all Schedule III controlled substances. This is very commonly used in dentistry, the hydrocodone combined with acetaminophen. And it goes under brand names like Vicodin and Lortab. So it comes in all different dosages. There are pills with 2.5 milligrams of hydrocodone and 500 milligrams of acetaminophen in each tablet, 5 milligrams of hydrocodone and 325, all kinds of different formulations. Basically, I think what dentists do is they become most comfortable prescribing one of these, and they pretty much give everybody the same stuff all the time. Let's just clarify for a point then. Just to clarify, I'll write it right down here. So we have morphine, and morphine is given by injection, but what's equivalent in efficacy to morphine that you can take orally is oxycodone. What's weaker than morphine is codeine, and what's kind of similar to codeine is hydrocodone. So I'm simply trying to draw a very rough approximation that oxycodone is to morphine as hydrocodone is to codeine. All right, so which one's more powerful? Morphine and oxycodone. Which is less powerful, codeine or hydrocodone? Percocet is more powerful than Vicodin. On page N7, they also have hydrocodone with aspirin and hydrocodone with ibuprofen. The one with ibuprofen goes under brand name Vicoprofen. That's cute, isn't it? Has anybody ever heard of that?
No.
So you might say, well, is that really different from Vicodin? No, not that much. Only the extent that ibuprofen is a little bit more effective anti-inflammatory than acetaminophen is. Hydromorphone goes under a brand name of Dilaudid. Dilaudid has been used in the past for like childbirth, for pain associated with childbirth. Now, what are the opioid synthetic narcotic analgesics? So these are totally synthetic. They are not made from the opium poppy at all. They are not made from the opium poppy at all. They actually have a different molecular structure that nevertheless activates the endorphin receptor sites like the opium alkaloids, but it is chemically different. And the classic example of that is meperidine, which goes under the brand name Demerol. It's primarily given by injection. It has a faster onset of action. I'm not testing you on any of this. It's believed to produce less constipation than some of the other narcotic pain relievers. And just as they combine acetaminophen with codeine, just as they combine acetaminophen with hydrocodone, that's called Vicodin, they combine acetaminophen with Demerol, that's called Demerol APAP. On page N8, Has anybody ever heard of Mupirgan? Mupirgan or Mupirgan fortis? This is where it's Demerol combined with an antihistamine called Phenergan. What is methadone? Methadone is very well absorbed orally, similar in potency to morphine. You may have heard that people who have addiction will be given pills of methadone to take so that they stop buying illegal drugs on the street and injecting themselves with illegal heroin. All right, that's called methadone. Fentanyl citrate, I'm not testing you on any of these, 100 times more potent than morphine. But what's fascinating about it is that it has a duration of action of only 30 minutes. So this has been used for IV sedation and in general anesthesia. They also have transdermal patches. My favorite here is China White, methylfentanyl, which is 1,000 times more potent than morphine.
Oh my God.
This one has a cute name, Imobilon. Imobilon, 400 times more potent than morphine. Just from its name, I am immobilized. So they have some pretty powerful narcotic pain relievers. On N9, I used to talk about Darvon. This was commonly given by dentists, prescribed by dentists, but the FDA withdrew it in 2010, a couple of years ago, because of the fact that it caused arrhythmias of the heart in some patients. Now, a drug that I would like you to know, I do want you to know about Tramadol. Has anybody ever heard of Tramadol? Tramadol goes under the brand name Ultram and some others. Interestingly, Tramadol has the potency in alleviating pain similar to that of codeine. Now, it was first introduced in 1995. What's very interesting is that it was not included as a controlled substance. So it did not fall under the overview of the Drug Enforcement Administration, or DEA. It was not listed as any controlled substance. So this became very popular to prescribe because the prescribers, be they dentists or physicians, it didn't require a DEA number. And the assumption was that it would not cause any physical dependency. However, over the last few years, it has become more apparent that in fact Tramadol can cause some degree of physical dependency. And while I wrote that Tramadol is currently not a controlled substance, in fact, effective August 18th, 2014, the Food and Drug Administration has declared or decided that it will be regulated as a Schedule IV controlled substance. Now, Schedule IV is still a lower level of enforcement than, for example, codeine itself. Codeine by itself is a Schedule II controlled substance, and even codeine combined with acetaminophen, in other words, Tylenol with codeine, is still a Schedule III controlled substance. So Tramadol is still a lower level. It is at the same level as Valium and Xanax, which are not used as pain relievers, but anti-anxiety drugs. So again, that does become effective, that Tramadol will require a DEA number. It can be prescribed on a regular prescription form. It does not require a tamper-resistant security prescription form, but that is effective August 18, 2014. Now, Tramadol is available combined with acetaminophen. It's sold under the name Ultracet, kind of cute, kind of a combination of Ultram and acetaminophen. It's actually available in a number of different formulations. This particular one is where each pill contains 37.5 milligrams of Tramadol and 325 milligrams of acetaminophen. And probably it would be taken 2 tablets, two pills at a time. Now what I have listed next is dextromethorphan. This is actually, as we wrote, a D-isomer analog of codeine. But it really has, it lacks any pain relief, analgesic effect, or narcotizing effects, narcotic actions. It, as we've described already, narcotic drugs, including codeine, suppress or depress the coughing reflex center, and therefore can be used as antitussives to reduce coughing. So dextromethorphan is specifically used for its antitussive action. It's available under the names Robitussin DM, and of course DM stands for dextromethorphan, and it's also available Benylin DM and Robilar. This is not a controlled substance. It is not, it's unlike Robitussin AC with codeine in it. This is not, does not have any narcotic effects or pain relieving action. It is used strictly for its antitussive action. These are all available over the counter. Drixarau. Drixarau is dextromethorphan combined with Sudafed or pseudoephedrine. Again, it's used for cold relief. The dextromethorphan is an antitussive for coughing, and the pseudoephedrine is a decongestant bronchodilator. There's a Dimetane DX. It contains dextromethorphan, brompheniramine, which is an antihistamine, and pseudoephedrine, which is a decongestant bronchodilator, an alpha-beta adrenergic agonist. Context, these are all again used for colds, available over the counter. Contains dextromethorphan as an antitussive, acetaminophen for mild pain relief, chlorpheniramine, an antihistamine, and pseudoephedrine as a bronchodilator decongestant. Now, we have listed next opiate antagonists, including naloxone and naltrexone. Naloxone goes under the brand name Narcan. Naltrexone goes under a number of brand names. These are given to reverse an overdose of a narcotic pain reliever. Naloxone and naltrexone have a very high affinity for the endorphin receptor sites, but they are antagonists, they are blockers. What, of course, that means is they have an affinity, they bind to the receptor site, the endorphin receptor sites, but rather than activating it, mimicking the action of endorphins, in fact, they do not produce any action, they block the receptor site. So they can literally push the narcotic pain reliever, the morphine, the heroin, whatever narcotic drug it is, they can kick it off the receptor site and then block it. If the person had developed a physical dependency to the narcotic pain reliever, the administration of naloxone causes the patient to immediately go into withdrawal response. On page N14, this is just a comparison chart comparing a number of different narcotic analgesics or narcotic pain relievers. So we can see that 10 milligrams of morphine is essentially equipotent, provides the same degree of pain relief as, for example, 1.5 milligrams of oxymorphone or 10 to 15 milligrams of oxycodone.